Good afternoon. My name is Alicia Sabartinelli Stein. I'm one of the Associate Program Directors here at the University of Miami, Department of Anesthesia, as well as an Assistant Professor in the Division of Pediatric Anesthesia. It is my distinct pleasure and privilege to have this opportunity to speak with you all today. Of course, this is a recorded lecture, but I will be available for questions that may come up after this session is done. So I'm here to discuss, are the children safe? An update on neurotoxicity-induced anesthesia in early childhood. I'm going to go ahead and turn on closed captioning as well, just hopefully to make sure that everyone understands what I'm saying. And in case I talk too fast, which sometimes I have a tendency to do. I have nothing to disclose. I do have a question to pose to the audience, and that is, what do masked T-Rexes and gassy pandas mixed with smart tots have in common? And basically, the answer is that all of these put together involve study and investigation into the most pressing issue of pediatric anesthesiology the last 2 decades. So 6 million children here in the United States, as I've pulled from the Center for Disease Control, undergo anesthesia annually. Of those, 2 to 3 million happen to be less than 36 months of age, and 1.5 million happen to be less than 12 months of age. So this is a lot of children with exposure to anesthesia, and some of the research and investigation that has been a large part of pediatric anesthesia as a specialty has involved this question of neurotoxicity for these children, and to make sure that we understand whether or not the agents that to which we are exposing them is safe. And on the global stage, worldwide, these numbers translate into the billions. Not only do we have billions of children undergoing anesthesia, we know that 1.7 billion children annually lack access to safe, timely, affordable surgical care and the anesthesia that's required to go with that. And in some countries, children make up 50% of that nation's population. So it is really, really of utmost importance for us to understand and do whatever we can to know and framework the medications that we give and provide to these children to make sure that we're doing it in the best way possible and remain safe. So that being said, maybe we're all healthcare professionals here. Have you had parents or family members of children that are your patients, or even friends and family within your community who they have children that have needed surgery, required surgery? Have they asked you questions such as this? Is anesthesia harmful? What, if any, other effects of anesthesia on my child? Does it cause brain damage? Does the anesthesia cause attention deficit or hyperactivity disorder or learning disabilities? And so a lot of this talk here is going to center around, what are these questions? Why are parents asking them? And I think we'll be able to understand a little bit later in the talk the why here. And then, but what is this perceived problem? And I put perceived in parentheses because it's almost, you'll see in a moment that there was sort of some chasing of a solution before there was a problem fully elucidated. So if you're ready to run away screaming, I don't blame you, but hopefully by the end of this talk, we will be in a better place. So the learning objectives of my talk today is that by the end of this session, you'll be able to synthesize the evolution of this literature surrounding this question of anesthesia-induced neurotoxicity, summarize the evidence of anesthesia risks of neurotoxicity in exposed children, if any, and identify the populations that might be at potential risk for anesthesia-induced neurotoxicity, and finally, to be able to appropriately respond with evidence-based responses to laypersons' concerns for neurotoxicity. But first, we're going to go a little bit back to the future. And I want to go through and give you some background about this evolution of this body of data. Where did we get to where we are today? And we'll talk a little bit about the preclinical and early clinical data, i.e. the animal studies and early retrospective data in children, and then some recent prospective clinical trials in infants and children. And then finally, how this public awareness or perception came about, and what our recommended responses should be. And really, do we continue down along this path? All right, but starting from the beginning, I wanted to just give you a very quick overview of the basically the development of the brain and intrauterus development of the brain, as well as early stages following birth. There's 4 main processes of brain development. One of, and you can see that here, basically neurogenesis, which is the development of the neurons. They migrate to their final places in the brain and then finally undergo this stage of apoptosis that starts in the last several weeks prior to birth and then continue on up into the age of 2, basically. And then about the time that the neurons are migrating, they're also starting to form synapses. So synaptogenesis starts around 20 weeks of following conception and continues on through birth. And then some of those synapses will undergo a process of pruning within the first several years of age. And then finally, those synapses and the neurons, the axons that are created undergo the process of myelination. And that's what you say in stage 4. This talk and this whole question of neurotoxicity centers on this process of apoptosis, which is programmed cell death. And at its peak, there's a natural process of apoptosis this idea of pruning and apoptosis, basically at its peak, 1% of neurons per day will undergo programmed cell death. There are 2 neurotransmitters that are implicated, and that is GABA and glutamate. And these are the main agents that are involved in instigate apoptosis. Synapses peak at age 1 to 2 years. And at this point, before they undergo apoptosis, there's 50% more synapses present in children than in adults prior to pruning. All right, so here is a list of our anesthetic agents and that are most commonly used. The majority of them here involve GABA or an MDA. And basically with the exception of the 2 on the bottom, which are opioids and dexmedetomidine that act on the class that mu opioid receptors as well as the alpha-2 adrenergic receptors, and they are agonists to each of those. So, and then you can see that we have NMDA inhibitors and then GABA agonists. Every day, these agents are being used in our children and as well as adults. So, and what's concerning is that also these 2 neurotransmitters, GABA and NMDA, are implicated with this idea of apoptosis. So there was a study in 1999. First author was Chrysanthi Konomidu, and this was an article published in Science. And it was titled here, Blockade of NMDA Receptors in Apoptotic Degeneration in the Developing Brain. And I highlight this last sentence of the abstract, basically suggesting that their findings where they exposed neonatal rats to high doses of ketamine and found widespread apoptotic neurodegeneration. And so they pose this idea that these findings may have relevance to human neurodevelopment disorders involving prenatal drug-abusing mothers or postnatal, i.e. not pediatric anesthesia, exposure to drugs that block the NMDA receptors. And the results of the study was that there was a 15 to 40-fold increase measured of neuroapoptosis post-exposure to ketamine in neonatal rats. So these neonatal rats were approximately at day 4 of life. And so here's a medallion of Helena Troy. And this article, I like to say, is the Helena Troy of this whole body of literature. It's the article that launched 1,000 other articles. And so Helena Troy was the Grecian woman who launched 1,000 ships. So this is a little slide from the article itself, demonstrating this uptick of neurodegenerating neurons, apoptotic neurons. So this Tunell staining marks degenerating neurons undergoing cell death here at the layer 2 of the parietal cortex. So this is unexposed brain here, parietal cortex, and this is exposed to ketamine brain. And so all of these little black dots are those neurons that are going apoptosis. So this was very concerning, and it is a very strong depiction of this event. So they also looked at PCP, which is another NMDA inhibitor. It's a drug that is used as a hallucinogenic and is used as a hallucinogenic, and also results in significant increases of apoptosis in the developing brain. And here are some electron micrographs of the degenerating neurons that you can see as like the nuclear membranes are becoming disrupted. So this effect was observed and was time dependent. So the longer these neonatal rats were exposed, that had an increase in the amount of degenerating neurons. And then also the dose, it was dose dependent as well. So the higher the dose, the more apoptosis was measured. So following this study, there was a lot of mumble and rumbling within the community. And so the Helen of Troy's 1,000 ships, basically that subsequent to the study, as of 2016, 440 preclinical and animal studies were have been published to date on this, trying to investigate neurotoxicity. And then since 2009, or as late as 2019, over almost 100, in fact, 76 clinical studies have been published on this topic. So here's the sort of like a conceptual framework as to how these articles, or what domains of investigation the articles have undertaken. So you have in vivo or in vitro studies, which are basically the preclinical models. And then you have our clinical studies that are basically our investigations into children to try to see if these findings that we're demonstrating in animal models could be replicated in human models. So of the preclinical and animal studies, basically many of these studies first looked at just what's happening at the cellular level, right? Increased apoptosis, diminished neurogenesis, changes in the dendritic spines, and so on. So these are all at the cellular level, right? So exposure to anesthetic agents with implications happening cellularly. So that's the earliest studies linking these two events together with exposure to anesthetic agents. The second phase of animal studies looked at the neurotoxicity following exposure and how did that translate into cognitive function or behavioral changes. And then finally, these behavioral changes, human models or human clinical studies, the efforts have been to translate these particular adverse health effects, cognitive changes, and translate them into relevant effects in pediatric patients. Many of these have been retrospective, few have been prospective in nature. And so we'll go a little bit over some of these. So to start with, preclinical and animal models basically are concluded, in summary, conclude this, basically that in animal research studies, when administered during rapid periods of brain growth, so early life, all of these anesthetics and sedatives commonly used in infants and children caused widespread loss of nerve cells and also associated abnormal behavior downstream. This effect was demonstrated across many species, from low order species such as worms all the way up to primates with different agents as listed that impact the NMDA and GABA receptors, as you see here, as well as those affecting different domains of cognition. So memory, behavioral changes, recognition changes, and so on. So, but in summary, in total, hundreds of papers utilizing these animal models found replication. They were able to replicate the findings of acute neurodegenerative changes and long-term neurobehavioral changes. They were consistent and reproducible, basically showing that single long exposures to general anesthesia led to cognitive deficits in animals. And even multiple shorter lasting exposures during particularly vulnerable periods could also impair neurocognitive development. And here's a sort of summation of it all together, basically all of the different domains, right? So the exposure, there was structural and morphologic damage, which is damage to different parts of the basis of the neurons, right? And then you actually, which impaired function. So you actually also have impaired, for example, synaptic transmission, changes in long-term potentiation. And then you have, and they all interact with one another here. And then basically ultimately, both of these come and combine to lead to behavioral impairments such as slow learning, increased anxiety, slow psychomotor speed, and so on. So if you're feeling a little bit like this, like concerned and overwhelmed by all of this data, and how does that impact our children? Rightfully so, right? Because this preclinical data suggested that general anesthetics affect brain development in a very significant way, but that was not without limitations. These animal studies lacked surgical stimulation for the most part. So there was what was absent was surgical stress, pain, inflammation, and trying to tease out what that implication of that part of the perioperative, experience plays into this picture. Maybe it's protective. Consideration of interspecies brain development variations, right? It's very challenging to find the exact equivalent of a 6-month-old baby and what period of development that is equivalent to in a rat or a mouse. And sometimes there was insufficient data regarding the duration of the exposure, the number of exposures in some of these models, some of these publications. And sometimes the exposure was so long, if you think about how fast the rat or mouse brain develops, that the equivalent exposure time in the human brain would have been 3-4 weeks of consistent, continuous high-dose anesthesia exposure, which is certainly not clinically accurate or relevant, because even outside of the critical care world, I mean, it just is not something that's part of our practice to do high dosages continuously for such a long period of time. But nonetheless, our Food and Drug Administration here in the United States created an advisory panel in 2007 and basically said that they were worried enough by these preclinical trials that they decided there was a need to do further study and to look into these effects of anesthetics and these sedative drugs on the human brain that was developing, including long-term studies in neonates and young children. As such, there was a collaboration between our International Anesthesia Research Society, and they formed a public-private partnership called Smart Tots. And this was under the Pediatric Anesthesia Safety Initiative, basically about 2009. So they felt that there was insufficient human data, and this was a method by which they could prompt intense investigation on the effects of the human fetus, infant, and child. And basically the main question was, how do these results in animal models translate clinically to the pediatric patient? So Smart Tots, which is I love about the world of pediatrics, is that we always get to use cute pictures and funny, cute, acronyms. So tot being toddlers, and Smart Tots, a little tot is another word for toddler. But so that is the acronym is Strategies for Mitigating Anesthesia-Related Neurotoxicity in Tots. This is a nonprofit organization, finally was up and running by 2010. And they had 3 main goals in terms of the research that they would be funding. One of which was to look at a cellular level, right? To try to understand what is happening to the brain when there is exposure in the pediatric brain, looking at for periods of the increased vulnerability, as well as what types of doses, durations, and frequencies would potentially lead to neurotoxicity. Then the second sort of domain that they wanted to investigate was, how does this change neurocognitive and behavioral outcomes? So basically, would IQ be impacted? Would there be increased risk of developing learning disabilities and other types of behavioral disabilities? And then finally, what would be the ways in which we could prevent or mitigate any of this developmental anesthetic neurotoxicity should it be demonstrated? So let me just go into the kind of the basic areas of the clinical data that came out of these initiatives. So these efforts to translate, again, the findings of the preclinical studies to human cohorts. So there was 3 main areas of study. Primarily the first papers that were published focused on academic performance. The second area was really trying to look at, is there increases of diagnoses of behavioral disorders such as ADHD or learning disabilities, autism associated with those who had been exposed to anesthesia. And then looking finally at abnormalities of neurocognitive function, i.e. behavior, IQ testing, intelligence quotient testing, and so on. So this is a nice review that was published in Anesthesiology, which is our main anesthesia journal. supported by the the American Society of Anesthesiologists, and they do a really nice review on all of this clinical data. So this first domain, remember, is academic performance. And so basically just looking at grades, and there was 12 of these. These were all retrospective in nature. Grades matter to children, but are imperfect measure of brain injury, so it's insensitive. There's lots of other factors that may influence the outcome of grades, that it's very hard to tease out anesthesia exposure from other factors. These studies tend to be large population-based studies, and overall they found small differences in school performance in children who had had surgery anesthesia exposure at ages less than 3. And it was very difficult to power these studies. So the second domain, again, was the clinical diagnosis. So looking basically in large population-based studies as well, they tended to be retrospective in nature, and also primarily focusing on the diagnosis of ADHD, attention deficit hyperactivity disorder. Sorry, I just see a small typo. Learning disabilities and autism, and all of which were shown to have increased risk associated with early life insults. So being that the community knew that there's this early life can increase the chance of these disabilities, maybe anesthetic exposure could be a type of early life insult that would cause increased frequency of these disabilities. Also, of course, there are limitations, one of which is that the definitions of these diagnoses tend to change. There's inconsistent diagnoses across populations on different trends that take place, right? And so that makes comparison very difficult and also tends to limit generalization. Overall, some of the studies, but not all, found evidence of an association between surgery and anesthesia in early life, as well as in the increased risk of diagnoses downstream. They found those that did find an association found that this was greater with multiple exposures versus single exposure. And here's one of those: early exposure to anesthesia and learning disabilities in a population-based birth cohort, published in 2009. And so here is a nice demonstration that they're specifically looking at learning disabilities. And there was a higher incidence demonstrated here with multiple exposures to anesthesia, and percentage of those diagnosed versus one exposure, which is slightly above the baseline that you see here, with no exposure, which is the dotted dashed line. A meta-analysis showed this slight association with adverse behavioral or developmental outcomes in children who were exposed to anesthesia, as depicted by all of these tallies here on the right side of the bar. But the evidence was very spotty, and so conclusions were hard to be drawn. So to this point, single brief exposures had been shown to be relatively reassuring, that they would not necessarily cause harm. Prolonged repeated anesthetics were difficult to interpret. There was a lot of confounders, one of which is that typically healthy kids do not tend to undergo long repeated procedures, and that many of these children who do need to do so tend to have issues such as prematurity, cyanotic heart disease, and the questions here surrounding what type of inflammatory injuries exist, what type of chronic hypoxic insults exist, and how does that interplay with some of the downstream cognitive deficits that might take place. It's very hard to tease that out from the anesthetic exposure, as you might imagine. So then the last domain of this clinical data testing that's out there is that there are several studies that then started to look at neuropsychologic testing as the main outcome exposure. And those this neuropsychologic testing focuses on several different domains, as you see here, basically all coming together to form the IQ test, which is the apical test. So, and that's the most accurate test that can predict future function. Tends to be battery tests. And then in these studies, they would look at tests that focused on intelligence, learning and memory, and attention and executive function. Many of these were retrospective or ambidirectional, meaning that they retrospectively found children who had been exposed as well as their controls, and then prospectively administered these tests. Some advantages was that these tests could take place at an older age, so therefore they have a greater capacity of predicting function. Some domains tend to mature later, so that's one of the advantages. However, though, drawbacks were that they are logistically more difficult, expensive, but overall there was evidence of an association between anesthesia exposure and testing was mixed. So we'll talk a little bit here about a couple trials, one of which is the PANDA study, the Pediatric Anesthesia Neurodevelopment Assessment. The PI was Dr. Sun out of Columbia University, and this project got up and running in 2009 and went on for several years. And the purpose was to determine whether the use of anesthetic agents in infants and children have long-term adverse effects on neurocognitive development. This paper was ultimately published in JAMA, which is the Journal of the American Medical Association. It was a multi-center study with involving 116 sibling pairs. It was an ambidextrous cohort design, and where they did prospective neurocognitive assessments and retrospectively exposed children, and also were able to control with sibling matched pairs or sibling matches who had not had the anesthetic exposure. The surgery that these children had underwent were inguinal hernias in ages less than 3 years of old, and their siblings had not had the surgery and thus the anesthesia. This was an innovative study design. You were able to minimize genetic and socioeconomic differences between groups. It was well powered. Primary outcome was IQ, and they found that there was no difference in IQ scores or any other neurocognitive deficits. So the GAS trial. This is general anesthesia versus spinal anesthesia. There were 722 infants less than 60 weeks post-conceptual age, also undergoing inguinal hernia repair. This was all an international, multi-center, prospective, randomized controlled equivalence trial. What is unique about the GAS trial is that this is the first prospective, randomized, controlled trial that was able to be created on this topic, because it's very hard to control in a randomized fashion someone that should get anesthesia or not, to try to localize harm. So this was 28 centers, North America, Europe, Australia, New Zealand, supplied data to the study. The primary outcome was a full-scale IQ test at the age of 5, and secondary outcomes included sort of the equivalent IQ testing for younger children, which is the Bailey scale, and that took place at age 2. And this article was published in The Lancet in 2016. Was the secondary outcomes were published. Basically the IQ testing for the children when they were age 2, and this secondary outcomes showed that the outcomes between those that had spinal anesthesia versus those that had had general anesthesia were identical. Essentially, equivalence had been demonstrated. So this was a huge deal. This is now considered a landmark study in this whole body of literature. So with the GAS trial from the Lancet and the PANDA study, now there's starting to be cautious optimism that short anesthetic exposures may not lead to significant cognitive decline in humans. And, excuse me, but also consider that the GAS trial had yet to release the primary endpoint, IQ testing at age 5, and the PANDA trial may not represent the general population due to the high socioeconomic status and high IQ scores in the controls. So just to circle back, I think hopefully we all now understand a little bit of what the problem is after some of our, the talk in the last several minutes. But let's talk a little bit about how do parents hear about this potential problem? Why are they asking all of these questions? And at least here in the United States, we had several very concerning headlines pop up over the years. From the Washington Post, anesthesia may harm the brains of children under 3. Wall Street Journal, FDA says anesthesia can be harmful to children's brains. Like, this is very alarmist headlines here. Anesthesia may harm children's brains from WebMD. And what basically had happened was in 2016 and 2017, the FDA, which is the U.S. Food and Drug Administration, the agency that basically approves all of our drugs, allows them to come to market, released these drug safety communications on general anesthetics and sedation drugs in young children and in pregnant women regarding the risk potentially to the developing brain. And in 2017, they actually insisted upon a label change for the use of general anesthetics. This is an example of the label change. So in every the 11 most common general anesthetics that bind GABA or Nfda receptors, the FDA insisted upon this label change. And so here is that I actually took this picture myself right here from one of our propofol vials, is that there's a whole section on pediatric neurotoxicity stating that published animal studies demonstrate that these agents may result in neuronal apoptosis in the developing brain, resulting in long-term cognitive deficits when used for longer than 3 hours. So this is very concerning, right? And this had taken the medical community by surprise for several reasons. One of which was that basically the gas trial secondary outcomes had just been released, and they were reassuring. Subsequently, also that there was imminent reports of additional data that was to come out there, which we'll talk about here in a moment, regarding multiple exposures to anesthesia, and that's the MASK trial. And then there's also to date really been there have been a lack of any data regarding adverse effects on human fetuses. That really these label changes have been based purely off preclinical animal trials, and so basically it was just confusing the warning and timing took the field by surprise, especially with the imminent release of more data in the human model that would provide perhaps some clarity. And this FDA warning had implications and impacts, right? So there was a concern in the community that the FDA warning would cause unnecessary delays of indicated surgical procedures and diagnostic procedures that would require anesthesia that could potentially lead to increased adverse outcomes. And there was a question of, should we now put this in part of our informed consents? And if you look at one busy pediatric hospital that does 43,000 cases a year, and how many of those are done in young children and how many of those are prolonged for more than 2 hours, that's a lot. And that's a lot that we should consider, maybe the parents would be too scared to proceed with the surgery that was needed in that time. This particular hospital did change its practice and decided to include a discussion of these risks with all parents of children less than age of 3 about this potential risk, which is probably the more on the extreme side of things. So in response, the Smart Tots had already released a consensus statement of the use of anesthetics in infants and toddlers, stating, trying to summarize the concern and state that really in children that the data that's out there was reassuring, and that really we don't know enough to make strong conclusions. But finally, the MASK study came out, and this is the Mayo Anesthesia Safety in Kids study. And this looked at comparing unexposed children and single exposed children and multiple exposures. This was prospective as well, and they were looking at neurodevelopment outcomes, the primary outcome being IQ testing or intelligence testing. Secondary outcomes were neuropsychologic subdomains, parental reporting. And they found that basically, if you look here, single and multiple exposures, the intelligence quotient versus unexposed children, that there was very little changes in IQ points. In fact, non-statistically significant. The only sort of thing to point out is really that in terms of parental reporting, that sometimes it was statistically significant that parents of children who had underwent multiple exposures to anesthesia reported more problems related to executive function, behavior, reading, and so on. But really the main conclusion was that the anesthesia before the age of 3 years was not associated with deficits in general intelligence. And then in 2019, the primary outcome of the neurodevelopment of the GAS trial was released and demonstrated equivalence. There's no association between 1 hour of sevoflurane anesthesia in infants and a full-scale IQ at age 5 when compared to spinals. And this was the strongest evidence to date that a single brief exposure to general anesthesia was not harmful to gross neurodevelopment. So what is going on? And we have had over the years several different concerning findings in different domains that were elucidated in the animal models that never fully translated to clinical relevancy in human models. One of those is this compound A, which is a byproduct of sevoflurane when it is metabolized by some of our scavenging systems that would create this particular byproduct, and that was shown to be nephrotoxic to animals. So the kidney caused kidney injury, but this was never demonstrated to be harmful in humans. And so is this question of neurotoxicity coming down in the same path? You know, the animal models suggesting neurotoxicity may not be relevant into the pediatric population. And it's really hard to prove a negative, however, because of all of these confounding factors of hard to tease out the anesthesia from the surgery, from the comorbidities that children might have. And so to date, currently, it's just inconclusive evidence that there's adverse effects on human brain development. And more research overall is really needed on the impact of procedures on child health. And never is no anesthesia an option. So it's so challenging about this subject. All right, so when you look back to these questions that maybe you've had presented to you, how do we respond? And I say that it's complicated. So in a nutshell, we know now how that strong evidence, the short exposures to anesthesia at a young age, right? So less than 2 hours, less than 2 years of age, has been demonstrated to have no detectable alterations in neurodevelopment outcome. The good news is that most children that undergo anesthesia fall into a category of presumed less risk. Those that undergo surgery, only 11% of those tend to be less than age of 3. And of those, only 3% undergo repeated anesthetics at that young age. What is unknown is what is the effect of longer exposures, repeated exposures. But by far, the majority of children, I think we can say, are safe. And that's the comfortable truth. So the likelihood of developmental anesthesia neurotoxicity may not exist in routine surgical procedures occurring early in life. And again, like I said before, it's very unlikely to be able to prove or disprove this non-existence just by the nature of how challenging it is to create the strongly powered studies that would require you can't do randomized non-blinded controlled trials in children to this fashion, right? Because again, no anesthesia is never an option. So going forth, trying to figure out really who is at risk, who is vulnerable. Or is it children that undergo multiple repetitive procedures, such as children with eye disease that require multiple exams under anesthesia and surgery, sometimes in some of our institutions 30 times before they're the age of 10? Are there particular biomarkers in neuroimaging that can guide work going forward in a much shorter time frame? It would be really great to identify biomarkers for brain injury that we could use to study more clearly this question. In editorials, there may be high-risk patients, such as that have baseline cognitive or other coexisting disabilities that might result in issues that make their brains more vulnerable. And this is where I think the future needs to head. Basically, children maybe with congenital cardiac disease, fetuses, infants with complex surgical conditions may be at particular risk. And of course, children that are critically ill and requiring prolonged sedation in the intensive care units. So there's some feasibility studies underway right now. That's the T-REX trial that is examining the safety profile of dexmedetomidine and remifentanil with caudal anesthesia for lower abdominal surgeries. Basically, it's a dose response safety trial that needs attempting to elucidate the higher end of safe administration of dexmedetomidine. There's a phase 1 study of dexmedetomidine boluses and infusions in corrective infant cardiac surgery. And really the most importantly is how do we counsel our patients, right? So it's just not even being a pediatric anesthesiologist, but just someone who's a physician in the healthcare setting. You're often asked questions that may not be your particular domain, but especially, we all have children, or we are related to children, or we have friends with children. So somehow, some way, you may get a question along these lines. And so it's important for us to be aware and conversant of the available evidence. We need to recognize that there are times that when there are indicated procedures in pregnant women and children that it's rare that they can be delayed, right? So there are some cases that when they need to go, they need to go. And there's nothing that we can do about that. That there's often few alternatives to many of these drugs, right? I mean, sure, if we could just avoid these drugs altogether, then that would maybe be the safest approach, but there's really not many alternatives. One of which, though, is maybe considering neuraxial anesthesia to the greatest extent possible in young infants. especially for those cases that are of lower abdominal and lower extremity procedures. And trying to utilize agents that act on alternative receptors, such as dexmedetomidine and higher opioid-based anesthetics. We recommend for parents and caregivers to always reach out to their medical professional to make sure that they understand the timing of a surgery that's being recommended. Can it be delayed? Can we wait until many surgeries, such as, let's say, for example, an umbilical hernia repair that can be delayed as long as it's not being incarcerated or, a risk of that is too strong. It's very common to delay many of these surgeries until they're older and further away from that period of high neurodevelopment that might potentially put them at more risk. How can I ensure my child has a successful surgery? And that's also just preparing them well for surgery, right? So just asking questions that are outside this issue of neurotoxicity. How can parents help their child to prepare? But also just really asking if anesthesia is safe for their child so that they can be fully educated themselves. So that basically wraps up my talk. And I just wanted to end with just the ASA is very aware of this issue and really putting a lot of blasts out there to try to educate the populace about knowing that it is safe for their children overall to undergo anesthesia and to receive this life-saving care. And I am, again, really happy to be here today and looking forward to answering any questions. Thank you.
I have to give a big thanks to dear Dr. Alicia for nice and awesome lecture. We enjoyed a lot. You know that it's so exciting that you see a lecturer did this much effort to make such an amazing and such an update, informative lecture. It was our pleasure and our honor. Let's move to next lecturer. I want to honorfully introduce you, dear Dr. Luis Rodriguez. He is an associate professor of anesthesiology at the University of Miami Jackson Memorial Hospital. He obtained his medical degree at the Universidad Central de Venezuela, Luis Rossetti School of Medicine, moving to the US and completing his anesthesia residency and pediatric anesthesia fellowship at Jackson Memorial Hospital. He currently serves as the chief of the division of pediatric anesthesiology at the University of Miami. Dr. Rodriguez also serves as the co-director for informatics, helping manage the intraoperative records for Jackson Memorial Hospital. His research interests include using the EMR to improve patient safety and physician quality metrics, awareness, and OR efficiency. He currently serves as the chair of the program committee for the Florida Society of Anesthesiologists Annual. Dr. Rodriguez serves as a faculty mentor for medical students, residents, and fellows. In his free time, he enjoys spending time with his wife, Melissa, and children, Ignacio and Alejandro, outdoors, fishing, running, stand-up paddleboarding, and camping. So nice to hear that. We are really, really honored to have dear Dr. Luis Rodriguez with us. We are going to enjoy his awesome lecture too.
Hello and good evening. My name is Luis Rodriguez, and I am a pediatric anesthesiologist working for the University of Miami in Florida, United States. First of all, I would like to thank the Tehran University of Medical Sciences for their invitation to participate in this congress. And I would like to talk to you about foreign body aspiration in children. I have no disclosures. And these are the objectives for my lecture today. First of all, I would like to go over a case as we talk about and touch some of the points and objectives of this lecture. We're going to present a case of a 16-month-old girl who was being fed by mother and developed a sudden episode of cough and difficulty breathing, for where she became pale and mother decided to call the emergency services and was transported to our hospital. So what is a choking episode? Obviously, as we can imagine, any child grabbing their neck, it's an acute episode where they have difficulty in breathing due to a foreign body, either organic or inorganic. And as you can imagine, it has a high sensitivity if it's witnessed. But it's the blockade or hindrance of respiration by a foreign body and an object that obstructs whether the internal airway at the level of the larynx or farther down the airway, all the way to the alveoli. 19% of these cases can be presented at 1 month after the episode of choking, even though it was found to be present in almost 90% of these cases. Some of them resolve and the foreign body maintains in the airway and even up to a month, as it shows in this study by Mayo. Who's at risk? Mainly, we can see that children are at risk, but we find that the highest peak is between 1 year and 3 years of age as a child starts exploring. If we look at the incidence of death in the United States between 1999 and 2017, in the age of children younger than 1 year of age, it was suffocation was the leading cause of death. But in this part of the data, it includes also episodes of sudden infant death syndromes and other reasons for suffocation, and not only foreign body aspiration. But in the group of children of 1 to 4 years of age, it's becoming increasingly common, and now is the third leading cause of death due to suffocation, which in this case, or in this age group, it is due to foreign body aspiration. As we can see in this graph, and multiple studies show that the highest incidence is in boys, as they tend to be a little bit rowdier or adventurous in exploring and putting things in their mouth. Most of us that are parents, as we begin to prepare for our first child, we start assessing and evaluating the web, and most of them, the first thing that they say is making the home safe for and preventing suffocation in children. Why is the children more at risk? Basically, there's many reasons. They don't have molars to destroy whatever the foreign body they are. This is their main way of exploring their surroundings. They have some vulnerabilities where they haven't developed the swallowing and chewing, and tend to run with foreign bodies in their mouth, and they don't know how to protect their airway so it can be swallowed and aspirated. What is the national cost? It has been studied of about $12.8 million per year for these events. There's an incidence of approximately 4% that lead to death or anoxic brain injury. In India, there was a study done by Gore in 2005 where they saw that 36% of these episodes arrived dead or did not make it to the emergency department. 50% of these cases perished or died during the intervention to remove the foreign body. And a smaller percentage, close to 14%, was found to die due to complications after the removal of the foreign body. Usually what's being eaten at this age usually is anything that is being found on the floor, or any objects, and they can be either organic or inorganic. But as we can imagine, not all shapes obstruct the airway equally. And obviously on this graph, you can see many shapes. And there's a very interesting study done by Brown. They looked at cadaveric or patients who had perished after foreign body aspiration, and grapes were found to be the number 4th cause of objects found in the airway in patients who had died. Again, organic items usually tend to be swallowed or aspirated in younger children, versus inorganic items tend to be found in older kids or even teenagers. Many different foreign bodies, usually if you have the organic types, depending on their country, this meta-analysis looked at the different nuts and seeds, and based on their location or country, you would see higher incidence of them, of one particular type of seed or foreign body. What are the stages? As we said before, you have the acute episode where the choking is occurring, where the child is trying to defend by coughing, increased respiratory rate, stridor. But once your body defense passes or is lodged, or the mechanisms of of defense are exhausted, you have this asymptomatic stage that can vary in length until you start having the symptoms of complications like a pneumonia, fever, and similar episodes of continuous wheezing. The typical triad described found in these cases, up to 60% of them, is cough, tachypnea, and stridor. And depending on the depth or the location of the foreign body, usually you might find wheezing or diminished breath sounds on the side of the foreign body location. In what to do in the acute event, as we know, most of the societies in cardiac, if the child has lost consciousness or is struggling, you can deliver 5 back blows or turn around and do chest thrust. There is this new development of new devices that are becoming more and more frequently used, where they basically are airway clearance devices that generate enough negative pressure by a sort of like a suctioning cup. And there's more and more evidence to show that there might be beneficial in cases where the patient has lost complete consciousness due to a foreign body in the airway. This is new literature coming more frequently, and I think this is something that we can start to see more and more in our emergency departments or even at home or in schools. A very complex slide done by the Calgary Guide Group, basically talking about the pathophysiology of foreign bodies in the airway. As we know, or we can imagine, balloons tend to be the ones with the highest mortality because they're smooth, they're flexible, and once they are aspirated to the airway, they adapt to the airway and they're very difficult to remove. In that sense, that's why they have the highest incidence of death. Once it's aspirated, we can divide them in upper airway or lower airway. When we talk about the upper airway, you can imagine that if it's a partial obstruction, you will have inspiratory stridor, agitation, this increased work of breathing and respiratory rate, or a hoarse voice, depending on the location, if it's at the larynx. Now, if it's a complete obstruction, there's no airway exchange that rapidly advances to hypoxia, bradycardia, and arrest. If we look at the lower airway obstruction, then you have the foreign body lodged into one of the lungs or lower at the carina, and then you will have tachypnea or increased work of breathing. You might find wheezing based on the location, and also maybe unilateral hyperinflation on the X-ray with decreased breath sounds on the side of the foreign body. Where do we find these foreign bodies? As we can imagine, there's 13 to 18% in the larynx or trachea, but the most common site is the right lung. Then bilateral is a lower percentage, and then on the left lung is the second most common place, with finally at the carina in very low percentage. As we said before, once the asymptomatic phase occurs, then depending on the length of time that is spent in the body, we're going to see many different complications, from the typical original pneumonia, but this can advance to pulmonary atelectasis, bronchiectasis, and even lung consolidation that would require lobe removal or resection. We have to always think of foreign bodies being aspirated when you have a child in the emergency department with worsening asthma that doesn't improve with treatment, and in an X-ray might be presented with a pneumomediastinum or subcutaneous emphysema. What are our diagnostic tools when we assess these children in the emergency department? You have what they call in this study by the Europeans, the penetration syndrome. It's just a clinical history with depends on the studies evaluated here, different sensitivities and specificities. Your chest examination done by the physician, and added, you can do a chest radiograph or even advance it to a chest CT. But up to 98% of your cases can be diagnosed by a good clinician doing a good physical exam and a chest X-ray. We know that very few objects, less than 10%, are seen on X-ray, and almost half of your X-rays are found to be normal. So what are the things that we're going to look for? Basically, you want to look for a hyperinflated lung on the side of the foreign body, as it might let air go into the lung and expand it, but it doesn't let the air come out. So it acts like a valve. In those cases, again, air hyperinflated lung, air trapping, this can eventually become atelectatic. You have a mediastinal shift, or you can even have, depending on the length, pneumonia or pulmonary infiltrates on the side of the foreign body. These are different examples of foreign bodies that we have removed in our center. And then we always come to the evaluation and the question of how do we know on an X-ray if the foreign body is in the esophagus or in the trachea. And as you can see, the black arrows point out to the airway, and the white obviously showing the foreign body. When we're talking about the foreign bodies in the esophagus, especially discoid foreign bodies like coins or button batteries, in the anterior posterior view, you're going to see the discoid shape. And on the lateral view, you're going to see it on the narrowest point of the shape of the coin. Versus in the trachea, as you can imagine, with your view on your right of your larynx, if the coin or battery tries to go past the vocal cords, then it has to be in your anterior posterior view. That's where you're going to see your narrowest diameter, versus on your lateral view, you're going to see the discoid shape trying to pass through your vocal cords. Currently, with high resolution X-rays or imaging and the new request for the battery makers to put ways to be seen or identified on X-rays, you can see a double halo on the discoid shape, or the AP in this AP view on the left. And on your right, you can see on the edges, you can see a two-step, which shows how the batteries are made. This is signs of a battery, and then again, an urgent need to be removed. Computer tomography, very high sensitivity, and specificity varies, but it's pretty good. The only problem is you need high radiation, and it's not routine use. It's not recommended. As we said before, with your good clinical history, your physical exam, and an X-ray, 98% of them can be diagnosed. It does help in foreign bodies that cannot be diagnosed easily, and it also helps guide your surgeon or your ENT to find the foreign body location. Virtual bronchoscopy, fancier technology, again, not necessarily recommended as a routine, but in cases where the foreign body has been dislodged or broken in multiple pieces on the attempts to be removed, this is a good tool to use in order to identify the location of the multiple pieces. We go back again to our case. And in our case, and you can see on the lateral X-ray, there's a shape at the level of the larynx, where here in closer view, you can see that there's something there that is lodged right at the entrance of the larynx. So what should be, or what is the common pathway to follow for us or guide us into what we need to do? In some places, or in some countries, like in the United Kingdom, here in China, and Italy, basically, they all go through the same, where if a child is having a distress, is coming in and the foreign body is located in a way that is obstructing the airway and the patient is in distress, it goes straight to the operating room, where you have to do rigid bronchoscopy and remove the foreign body. Now, in the case that the patient is stable, then you might consider, as shown in this graph by the Italians, and they propose the use of flexible bronchoscopy, and we'll talk about it in a few slides. Now, in the United Kingdom, there's a quote, in this study, what they were discussing is there is no need in children who are stable and they come at night to proceed to the OR the same day, where there's less support and less of the best capable hands or physicians to help remove the object. So they propose waiting for the next turn in the OR the next day. Obviously, if the patients are clinically unstable, they should, in respiratory distress, they go immediately to the operating room. But as we know, in a letter to the editor following this article, as the use of button batteries becomes more and more frequent for hearing aids, for other devices, we might find a case like this, where even though if the patient is stable, this case needs to go. And as a recent study discussed here in the American Patient Safety Foundation, in February of 2022. Basically, although bottom batteries tend to be ingested more commonly, if a bottom battery is found in the airway, you have to remove it immediately because of the alkali production or by the mucosa. On the mucosa, it will start liquefaction and necrosis of the tissue within 15 minutes. Even though it is most commonly ingested, and here's the recommendation of using honey or acidic liquids in order to cover and protect the battery and protect the alkali produced by the battery in destroying or injuring the mucosa. So, as anesthesiologists and what other physicians are going to help us determine how to proceed and where to go is we want to make sure how's the airway patency, is a stable patient versus in distress. Do we know by the parents or the surgeon what was aspirated, where is it, how long has it been? Is the patient NPO or is a full stomach? And do we have an IV access? And if we don't, should we put it before or after we put the patient asleep? Now, what is the ideal anesthetic technique? It should be one that provides adequate oxygenation and ventilation throughout the removal of the foreign body. It guarantees continuous ventilation, provides adequate depth of anesthesia so the patient doesn't cough or balk during the manipulation of the foreign body. And as soon as the foreign body is removed, it provides a rapid emergence and wake up with minimal environmental pollution. Now, this is the ideal one. Doesn't mean that we have it, but we have enough tools to provide something very close to this. If we look at what the pediatric anesthesia textbooks say, even if a child comes in with a full stomach or having a meal and then aspirating, the airway takes precedence. So we just take over the airway and recommend it's an inhaled induction, even though there's a risk that the patient might vomit and aspirate more bodies, but the maintenance of spontaneous ventilation takes priority. What are some of the drugs? Basically, sevoflurane is one of the inhaled anesthetics, and it's the one recommended in children breathing spontaneously, as it's the least pungent. If you have an IV, propofol is one of the most recommended drugs to provide intravenous anesthesia, although there are other tools available in our drug armamentarium. The combined approach of sevoflurane plus a propofol, dexmedetomidine, or ketamine, and topicalization of the airway with lidocaine is one of the most recommended techniques. It is said that, or it's recommended that spontaneous ventilation be done as it helps preserve laminar flow, but there are scenarios where you can do positive pressure ventilation. The concern of using positive pressure ventilation is theoretically you can push the foreign body down deeper into the lungs, but this is a theoretical concern as it has not been shown to be a clinical concern. Definitely avoid jet ventilation, as the foreign body can act as a valve and you could have a pneumothorax because of the entrapment of air and the high speed or high pressure jet ventilation. So what is our plan? We have to always, depending on, as we said before in our pre-op assessment, if we're going to do a total intravenous only, or we're going to do volatile in what VIMA means is volatile induction maintenance of anesthesia. So meaning you're going to use only inhaled anesthetics, or what we're going to show is that the mixed technique is the most recommended one. Should we maintain a spontaneous ventilation, or we use the machine to control the ventilation, and whether we need to do muscle paralysis for these patients? Going back to our case, so we were able to get the parent and the child into the room, as that provided some sort of comfort for the child. We were able then to proceed and do inhaled induction, and child we were able to maintain a spontaneous ventilation while we deepened the patient, and then we obtained the IV. The reason we chose this is the location of the foreign body at the larynx and the child crying while we try to obtain the IV. Then it would risk the foreign body dislodging and potentially doing a full obstruction of the airway. discussion of when to get the IV. There's some literature that goes back and forth of when it should be done in order to provide a intravenous induction, or should we do after inhaled induction. But basically, most of the studies, what they say is it's based on the team's preference and experience, and knowing where the foreign body is located, that if you risk the patient crying and upset, might dislodge the foreign body and causing total obstruction of the airway, then you might decide to do it after a controlled inhaled induction. But obviously the experience and the preference of the individual anesthetic team is what makes the most important decision. Now, to paralyze or not to paralyze, I know another area where there's a lot of evidence showing back and forth, but basically what we find and the way we decide or the way we practice is that if the foreign body is in the main airway, trachea, larynx, or carina, then you want to not paralyze and maintain spontaneous ventilation, or even control ventilation, but do not paralyze so the patient can recover spontaneous breathing. But if the foreign body is lodged in one of the distal airways or distal bronchus, since you might need to do rigid bronchoscopy, you don't want to risk the patient coughing or bucking during rigid bronchoscopy deeper into the bronchia. You don't want to risk of injuring the bronchus with the instrument. So you might consider in these scenarios to use muscle paralysis and control ventilation. There was a higher incidence in this study, the higher incidence of body movement and breath holding with potential laryngospasm, I apologize, with the total intravenous only and in spontaneous ventilations. But also they found that when you use inhaled anesthetics alone, it can lead to hypoventilation and leaks. So the rest of you can contaminate and expose the rest of the team in the operating room to your inhaled anesthetics. Another study that compared the use of inhaled anesthetics alone with the use of versus the use of intravenous anesthetics alone. And on this, we find that with the inhaled anesthetics, they provide more stable hemodynamics and respiration, faster induction and recovery. They had less adverse events like breath holding and desaturation. But as we can imagine, there was more emergent delirium in the group that used inhaled anesthetics on their own. Now, this is a better, more appropriate study where they compared TIVA only or intravenous anesthetics with propofol and remifentanil against propofol and sevoflurane, where we start seeing the mixture of inhaled anesthetic with intravenous anesthetics and topical lidocaine. And as you can see on the table on the left, the incidence of adverse events was much less in the mixed group. So what are the tools and ways for us to remove this, and how can we help our surgeons? Is obviously rigid bronchoscopy is the indicated and ideal instrument and recommended by the American Thoracic Society as the safest and most preferred method, has the least amount of morbidity and mortality, as low as 0.42% in all the foreign body removals in all these studies done. Now, flexible bronchoscopy was proposed, and in some scenarios can be done under sedation and provides safe examination in those cases where there's a concern for foreign body aspiration, but neither the physical exam or the x-rays can show where it is. The only problem with flexible bronchoscopy is that it doesn't necessarily improve the risk, as you have a higher chance of dislodging the foreign body and causing a complete obstruction. In this study from Italy, again, they found that if in those cases where there's the concern for foreign body, even though you can't see it, if you don't find foreign bodies with a flexible bronchoscopy, you can spare that patient a general anesthetic and the risk of general anesthesia, and eventually potentially save about $1,400 in 2007. Again, flexible bronchoscopy was considered only in older adolescents and young adults, but now we know that based on the expertise of the surgeon or the ENT physicians, they are able to do it even in neonates. But their experience is what determines and what shows in this wide range of successful from 10% to 90% of patients. Some of the potential advantages and disadvantages, as we spoke before. And then other techniques that you can be aware and how to use them based on the difficulty of removing these foreign bodies. Again, balloon dilations to remove foreign bodies. Here, they use a cryoprobe to dissect the scar tissue around it and remove the foreign body, or even considering the worst case scenarios, the use of ECMO to provide support while removing the foreign body. Going back to our case, communication is key, where we had the surgeon at the bed and we had all the instrument and equipment to remove it. This is the view of the foreign body in the larynx. And obviously you can see complete or partial obstructions at the level of the vocal cords. Once we remove the foreign body, you can see this big size and it was lodged right in the vocal cords. And as we removed the foreign body, we had some stridor. So we decided to paralyze, intubate, and provide steroids to decrease inflammation. Day 2 of the procedure, after the removal of the foreign body, the kid was extubated and was able to go home. What determines where they go after? If you do a flexible bronchoscopy and you don't see a foreign body, you can send them home. But if they need general anesthesia and removal of foreign body, these are the things that might determine where they will need to go from the floor to the ICU based on oxygenation after removal of the foreign body. So organic foreign bodies are worse, post-operative hypoxemia, prolonged bronchoscopy that is also considered more than 30 minutes, and it's based on the experience of the surgeon, where the 5-year mark shows a difference of their complication rates. And obviously, after the surgery, post-op worsening pulmonary lesions are signs of prolonged recovery. Almost half of these foreign body removals have some sort of complications, and the highest risk factors in this study were found to have if the foreign body was lodged for more than 1 day, and the bronchoscopy duration was more than 30 minutes. As the anesthetic technique was evaluated, they found that if you did intravenous anesthetic only, you had higher chance of complications than if you use, again, inhaled anesthetics only. But nowadays, we recommend using a mix of both. A small percentage can be broken apart based on the foreign body, and now the patient might need multiple interventions. Or if the granulation tissue forms, then you might have scarring and stenosis of your bronchial, and they might need future stenting or dilation as this prolonged and chronic issue might develop after the foreign body is removed. What's our goal? As all physicians, we understand that our goal is that the child has the minimal impact and is able to go home with the least amount of comorbid or complications after this event. What can be done? As we know, and as we spoke at the beginning, prevention is key. How do we do this? In this study in France, they basically, since the 1980s, where they had about 4 cases in 10,000 children, they started doing and promoting more education, and they found a complete decrease as they educated the parents and the school teachers and everybody, and raised awareness of the implications of foreign body aspiration, especially in the children and toddler age. Follow some of your society's guidelines and learning how to do choking and CPR. It's important. And also, as many countries are doing currently, they're changing their labeling of their toys. They're legally or at the state level, they're making sure that the food that can be at risk, you put markings on the food labels or on the toys where parents, when they buy them, they're aware of the risk of aspiration. My take-home message should be always do a mixed technique than one in particular. Spontaneous can always recommended more than controlled ventilation or paralysis. After the foreign body is removed, you should intubate the patient if they're not able to be saturation. And if you have an ICU, call them early and have them ready for the patient to be there. With this, I finish my presentation. Thank you very much. And here's my contact information if I can be of further service.
Thanks a lot to dear Dr. Luis Rodriguez for this awesome lecture. All we know that children are completely beside any region, any culture, anything. So foreign body aspiration is one of the biggest complex and complications all around the world. Anywhere there is a kid, so you will face foreign body aspiration at time. And it is very good to know about it, all of us as a physicians, especially anesthesiologists and also pediatricians. Dear doctor, we are so pleased to have your lecture. We are going to have the last lecturer. I'm going to proudly introduce you our third lecturer, dear Dr. Sina Ghaffaripoor. He is an assistant professor in anesthesiology in University of Mayo, Department of Anesthesiology. Transplant anesthesiologist, director of anesthesia for oncology surgery in University of Miami, Miami Hospital site, residency director in University of Miami Hospital. It's a big pleasure and honor to have dear Dr. Ghaffaripoor with us. We are going to enjoy his lecture, and after that we are going to have the panel discussion to asking questions. Enjoy the lecture.
Good evening, everyone. Thank you for inviting me. It's my pleasure to present this presentation here. My name is Sina Ghaffari. I'm a full-time anesthesiologist in the Department of Anesthesiology, University of Miami. I was asked to talk about the airway management in pediatric, and here we are to start the presentation. We know that anesthesiologists who perform fewer than 100 pediatric cases on infants and young children per year are 5 times more likely to experience complications compared with anesthesiologists who do more than 200 cases per year. The American Society of Anesthesiologists close claims analysis and the Pediatric Perioperative Cardiac Arrest Registry, which is called POCA, show that cardiac arrest and brain death in pediatric patients are still mainly caused by airway problems, despite improvements such as monitoring and oxygenations and capnography and many types of anesthetic medications. Between those respiratory complications, laryngospasm was the most common cause of respiratory-related arrests. Other etiologies were included airway obstruction, difficult intubation, esophageal intubation, and aspiration. Pediatric respiratory events carry a higher mortality rate than adult events. A young patient, increased parasympathetic tone, immature brain, underdeveloped respiratory center, and behavioral response increases the risk of airway complication and respiratory failure. Parasympathetic tone is increased in pediatric patients. That's why hypoxia causes mostly bradycardia in those patients. Bradycardia causes hypotension, hypotension causes hypoxia again. So it's a vicious cycle. Children easily sedated because they have immature neurons, they have less myelinizations, they have weak blood-brain barrier, and even little prior exposure to drugs increases the risk of respiratory depression. On the other hand, most of the children in a critical situation, they are scared to cry. That's why they have a lot of secretions, they have a lot of airway irritability. The risk of laryngospasm is increased, the risk of wheezing increased, and the risk of airway edema is increased. Of course, children are uncooperative and they cannot follow the instructions. Because of this, they struggle and fight, and the stress of the struggle and fight increases the metabolic rate. On the other hand, if you have a patient with who is premature, the more premature is the patient, the greater is the risk of respiratory complications. They have altered ventilatory response to hypoxia, ventilatory response, hypercarbia, sleep, and all of these can be made worse if the patient is stressed, cold, or really ill. Apnea increases the chance of hypoxia. Hypoxia increases the chance of bradycardia, and bradycardia worsens the hypoxia. So this is the vicious cycle in pediatrics. Pediatric anatomy is completely differs in four main ways with adult: in size, in composition, in position, and shape. It should not be surprising that the inside of the child is changing as well in compared to an adult. Infants who have the greatest anatomy differences have the highest risk of airway complication. As you can see in this picture, the difference between adult and pediatric airway is shown. Pediatrics, they have narrower nostrils, and although newborns obligate to be nose breather, but the nostrils are very narrow. They have rounded occiput. The size of the tongue is relatively large for the size of the mouth. Epiglottis is different. It is omega-shaped and floppy. Larynx is higher in the neck of the pediatric patients. Vocal cords slant anteriorly. The neck is shorter. And cricoid ring is the narrowest diameter in pediatric airway. The infant's large head relative to body size, rounded occiput, large tongue, and larynx positioned higher in the neck are predisposed to obstruction if the head flexes forward or the child loses consciousness. The laryngeal and tracheal cartilage are soft and easily compressed. Infants have suffocated while being held in an extreme flexed position during lumbar puncture. Studies of infants' positioning for lumbar puncture show that oxygenation and oxygen saturation drops significantly when an infant is held in a lateral recumbent position when the head flexed forward onto the chest, rather than the lateral with the head extended, or in a sitting flex position. So lumbar puncture can be a position or a procedure that makes the patient to be desaturated. The larynx itself has a different shape in pediatric. Unlike in the adult, the airway in infants and children is wider at the top, above the glottis, and narrows below the larynx in the subglottic area. The funnel shape predisposes the child to a greater risk for airway obstruction from processes causing subglottic edema, such as croup or intubation trauma. As you can see in these figures, the shape of the larynx is different in infant, toddler, and also adult. The larynx and trachea are so small that minimal swelling can cause tracheal obstruction in pediatrics. In an adult, 1 millimeter circumferential swelling with a 10 millimeter trachea causes only 44% decrease in cross-sectional area and triples the resistance to airflow. In an infant with a 4 millimeter trachea who develops 1 millimeter circumferential edema, there is a 75% decrease in area with an associated 16 times increase in resistance. But that's the difference. Infections such as croup or a coin stuck in the esophagus by compressing the soft trachea can place serious limits on the infant's or toddler's ability to breathe. As a child gets older, tonsils and adenoids often fill the airway, causing obstructive sleep apnea and difficult with manual ventilation. Hypertrophied tonsils almost meeting in the midline, which is so-called kissing tonsils, as you can see in this picture. If you look closely, you can see that the epiglottis and vocal cords are high enough in the neck to be seen behind the back of the tongue. Extreme extension or flexion of the child's neck can obstruct the airway. A child younger than 2 years, especially an infant, has a relatively large occiput and a neck which is very short. The larynx is higher in the neck, right behind the tongue. A pillow placed under the head of the infant or toddler will bend the head forward over the chest, force the tongue background, and worsen airway obstruction. It will also make it harder for you to tilt the head back to open the airway. Instead, you should place a small rolled towel under the shoulders in children younger than 2 years to open the airway. As the child reaches 2 years of age, the occiput gradually becomes less prominent, but is still rounded. Keeping the head in a more neutral position is helpful at this age. At some point in the older child, placing a roll under the child's head as you would with an adult improves the airway. The correct size oral airway places the flange immediately outside the teeth or gums and positions the tip of the airway near the vallecula. This is the correct size of the airway that we should use for the airway ventilation. An airway that is too small places the tip in the middle of the tongue, punching the tissues and worsening obstructions. It can obstruct the lingual vein and cause tongue swelling. Too large an airway extends from the mouth and prevents sealing the mask over the face. It can fold the epiglottis down over the glottis opening and worsen the obstruction. To estimate the correct size of the airway, place the airway next to the child's jaw, parallel the mouth, and judge where it will lie. The tip should extend from the center of the patient's mouth to the angle of the lower jaw. The infant's metabolic rate is roughly double the adult rate. Full-time full-term infants are born with 20 million to 50 million alveoli, about 10% of the 200 million to 500 million found in adults, giving them about 26 times less area for gas exchange. Surface area varying from 2.8 square meter in the infant, this is about the size of the baby blanket, to 75 square meter in an adult, about half a tennis court. Regardless of the age, a normal resting tidal volume is about 8 milliliters per kg of lean body weight. So for a 2.7 kilograms infant's tidal volume is only about 22 milliliters. Functional residual capacity, the amount of the air left in the lung after a normal exhalation, effectively acts as the lung's oxygen tank. The larger the FRC, the bigger the oxygen tank in any patient, and the more respiratory reserve. FRC is only 18 milliliters per kg in an infant, in compared to adult, which is 70 milliliters per kg. With a smaller oxygen tank, the infants can hold their breath very shorter, less than the adult, and they don't have any reserve. So that's why they are prone to be hypoxic very fast with apnea. To ventilate the child, we should have a good mask sealing. First, choose the correct mask size. The proper size covers the space between the bridge of the nose and the crease of the chin. Too large or too small a mask will prevent a good seal. The face of an infant or a toddler is a lot smaller relative to your hand. You will still use your thumb and forefinger to press the mask against the face. Unlike the adult, however, the size of your hand may not allow you to put all your fingers on the mandible. It's not uncommon in a small infant to use just your third finger on the jaw to pull the face into the mask, with the fourth and fifth fingers completely free. Don't press on the soft tissues under the chin with the remaining fingers. Pressure there, putting some pressure over there, can increase airway obstruction by pushing the tongue and epiglottis back over the laryngeal outlet and by compressing the soft laryngeal cartilages. Equipments before can increase airway obstruction by pushing the tongue and epiglottis back over the laryngeal outlet and by compressing the soft laryngeal cartilages. Note here that the third finger, again, on the mandible, and fourth and fifth finger avoid pressure over the larynx. Always have the right size equipments before you start. Make sure you have the appropriate sized equipment, especially ventilation equipment, immediately available for the child you are treating. If the mask you have is too large for the face, ventilation may be impossible. An incorrectly sized oral airway can make obstruction worse. If the ETT is too large, you won't be able to insert it at all. Pediatric intubating equipment should include Miller or straight blades in size 0 for infants, size 1 for age 1 to 2 years, and size 2 for older children. As you can see, we usually use a tube size 2.5 to 3 for premature. For the newborn, it can be 3 to 3.5. Up to 1 year old, the size of the tube can be up to 4, and the size getting larger up to adolescents and adults. Cuffed versus uncuffed endotracheal tube. Historically, we have used uncuffed ETTs in infants and children younger than about 8 years because the smallest diameter of the younger child's airway is the cricoid ring. A properly sized round ETT sealed the round opening. Uncuffed tubes avoided cuff pressure on the trachea, which was felt to place the youngest children at risk for subglottic injury and post-extubation croup. However, post-extubation croup can still occur with uncuffed tubes. Newer research has found that the cricoid ring is more elliptical in shape than round. A round uncuffed ETT placed into an elliptical hole can, despite the presence of a leak, put excessive pressure on the parts of the tracheal mucosa. This discovery makes use of uncuffed ETT less compelling. In addition, pediatric cuffs are now mostly the low-pressure types. It's therefore becoming more popular, and these are some advantages of using cuffed versus uncuffed endotracheal tube. Advantages are the cuffed ETTs, they can protect better against aspiration. They avoid tube changes, which can be a kind of airway trauma for a patient. For example, if the first attempt has been done with a smaller size tube and you want to change it, you can just adjust the balloon inflation. The cuff tubes allow higher ventilation pressure with poor pulmonary compliance. They allow more precise monitoring of the ventilation. They provide a more accurate tidal volume. The tubes release less OR pollution for leaking anesthesia waste gas. And they decreased risk for fire in the OR when an ignition source is present. The disadvantages of cuffed ETTs are they take up space and force use of a tube size 1/2 to one size smaller. We have to use a little bit smaller tube when we use a cuff tube. A smaller tube increases the resistance and increases the work of breathing. The size 4 ETT has a 59% higher resistance and work of breathing compared with size 5. There is a higher risk for plugging the smaller lumen with secretions. Suctioning smaller tubes is much more challenging. That's why suctioning of a smaller size cuff tube can be challenging. We go back to the techniques of intubation. Raising the shoulders can help position a baby for intubation. Regardless of the age, the air canal should be roughly level with the sternal notch. The infant's rounded occiput and large head often raise it too high off the intubating surface to obtain the sniffing position. Placing a small folded towel or object of similar thickness under an infant's shoulder raises the rest of the body and straightens the airway path. You can also stabilize the head with a small towel or washcloth curled on the either side. An assistant steadies the head while the intubator also uses his right hand to position the head. There is a maneuver for professionals, 3 digits of Fleming rules. As you can see in this picture, when you have a neonate or infant, you can use your right hand to position the head in a way that intubation becomes more easier. By index finger of your right hand, you can move the shoulder. By the middle finger, you can position the neck. By the thumb, you can open the lower jaw. And with your left hand, you use the laryngoscope. And with the maneuvers that you can do with these 3 fingers, you can make a good view of the larynx during intubation of a newborn or infant. Points about laryngoscopy and intubation. The infant's mouth is very small compared with the size of your hand. Failure to place your fingers far to the right can block your view and prevent blade insertion. The infant tongue is much larger relative to the mouth and jaw than in the adult. Failure to sweep the tongue to the left with your laryngoscope blade will leave no room for visualization for tube passage. It's very easy to insert the blade too deeply and into the esophagus of such a tiny patient. If you can't identify anatomy, then put the blade back slowly while you watch the larynx. Often the larynx will drop into your view. Remember, the cricoid ring is smaller than opening between the vocal cords. You can sometimes insert an ETT to the vocal cords, but not beyond the cricoid cartilage. Forcing an ETT can cause traumatic swelling. If the ETT won't pass, always use a smaller one. Deciding the initial depth of ETT insertion, which is called ATL, at the lip distance. The most familiar formula for calculating ETT depth applies to children under 2 years. And you can use the age in years divided by 2 plus 12. For infants and children younger than 2 years of age, you can calculate the ETT depth by using this formula. Depth ATL, or at the lip distance, can be calculated. The size of the ETT that you are using, the interior diameter, multiple 3. For example, if you are using size 3 of the tube, multiple 3, the ATL can be 9 centimeters. Formulas for ETT depth of insertion have been clinically validated for neonatal patients weighing more than 750 grams up to 4 kilograms. For these patients, you can add 6 centimeters to the weight of the patient. So if the neonate is a premature patient with only 1 kilogram weight, the distance of the tube ATL at the lip can be only 6 plus 1 equals to 7 centimeters. Although these formulas are reasonably accurate, you still must verify bilateral breathing sounds, as children of the same age can vary very, very much. Esophageal intubation and mainstem intubation accuracy is it. You must constantly be alert to potential misplacement of an ETT in pediatrics. Verify optimal placement every time you reposition the child. The difference between intubation and extubation in a neonate can be only 1 centimeter. Extension of the neck causes the ETT to rise within the trachea. Inadvertent extubation can occur if the tube is too high. Flexion of the head causes the tip to descend, possibly causing main stem intubation and one lung ventilation. Never forget to ventilate the patient. It's easy to lose track of time during an intubation when the baby is apneic. Infants and young children can hold their breath as long as adults. They don't have enough FRC before the onset of the hypoxia. Stop and ventilate if the intubation attempt is taking longer than 30 seconds to 1 minute. You can start ventilating the patient again and attempt for intubation again. Being proactive about ventilation will help avoid oxygen desaturation with its risk of cardiac arrest. Not every child needs intubation. Suprachorotic airways such as laryngeal mask airways are less stimulating, less traumatic, and are often easier than intubation for the occasional pediatric provider to place. Laryngeal mask airways are available in sizes for babies as small as 2 kilograms. But the weight-based size chart really can be difficult to remember. Choose a pediatric laryngeal mask airway by comparing the size of the cushion to the child's external air. This technique has a 93% success rate, comparable to that of the size of the chart. Choose your patient carefully. With the laryngeal mask airway, laryngospasm or aspiration can still occur with the laryngeal mask airways. You won't be able to deliver higher pressure breaths with LMA, especially if the compliance is poor. Always be prepared for more advanced airway management. Always be prepared for laryngospasm during the airway management of the pediatrics. When the laryngospasm occurs, vocal cord closure can be so forceful that it can prevent all ventilation or even the passage of the ETT. Life-threatening hypoxia can quickly follow. Other potential complications include post-obstructive pulmonary edema and possibly even cardiac arrest. The incidence of laryngospasm during anesthesia is higher in children than in adults and ranges from 1.7% to 25%. Of cardiac arrest found in the POCA registry, 27% result from respiratory events, and laryngospasm was the most common cause of respiratory-related events, followed by airway obstruction, difficult intubation, esophageal intubation, and aspiration. You can see closure of the larynx occurs by 4 mechanisms. Closure of the vocal cords, both by pulling them together and by tensing. Closure of the false vocal cords, mounting of the paraglottic tissues, lower epiglottis, paraglottic fat, base of the tongue by elevation of the larynx. And the last one is folding of the epiglottis over the glottic opening, as you can see in figure B. Avoid laryngospasm is the best treatment of laryngospasm. Laryngospasm is most likely to occur when secretions, mucus, blood, or instruments such as a laryngoscope stimulate the vocal cords in patients who is lightly anesthetized or in stage 2. Prime times are during intubation or immediately following extubation. However, laryngospasm can occur with the best of care, especially in patients with irritable airways, such as those with asthma those with upper or lower respiratory infection, and in the presence of airway anomalies. There are measures to manage laryngospasm. Consider postponement of the elective surgery if the child has significant upper respiratory infection or active wheezing. Never stimulate the airway in stage 2 anesthesia. Don't extubate if the child is actively coughing. Their time removal for quiet breathing when the cords will be open. Keep the airways clear of secretions and consider a muscle relaxant during intubation of a high-risk child. And if it happens, please recognize the laryngospasm. Laryngospasm can be obvious or subtle, but it always shows signs of airway obstruction. Depending on severity, there may be a very little chest or ventilation bag movement with spontaneous ventilation. When laryngospasm is complete, no ventilation is possible. Signs of airway obstruction include rib retraction, tracheal talk, and rocking breathing movement or paradoxical chest movement. Chest falls and abdomen rises with inspiration. There will be stridor if laryngospasm is partial. However, stridor won't occur without some air movement. And if it happens, break the laryngospasm. Once the reflex is triggered in semi-conscious patient, it often persists for a dangerously long time. However, if the spasm is not broken, hypoxia will develop quickly and can lead to cardiac arrest. Waiting out the spasm usually isn't an option. To break laryngospasm, first stop stimulating the vocal cords. Suction the airway. Sometimes simply removing the object that touched the vocal cords or the secretions is enough to break the spasm. Alerts your colleagues. You never want to manage a laryngospasm alone. Never treat laryngospasm alone. Direct all efforts to delivering oxygen. Apply your ventilation mask tightly against the face and provide a continuous positive pressure breathing with your ventilation bag while performing a jaw thrust. If laryngospasm is not breaking quickly with positive pressure ventilation, maybe a little bit of sedative drugs such as propofol is needed. And if even with the propofol is not treating the laryngospasm, you should use a short-acting muscle relaxant such as succinylcholine. But never wait for the laryngospasm to resolve by itself. This CT scan shows a retropharyngeal abscess in a 5-year-old girl. Note the distortion and deviation of the trachea, just as in adults. Video laryngoscope, like the GVL, can help in a difficult airway situation in pediatrics. 4 sizes of pediatric GVL or glidoscope are currently available, and pediatric sized blades are usually chosen by patient's weight. As you can see, GVL 0 is being used for weights less than 1.5 kilos, size 1 for the weights between 1.5 to 3.6 kilos, GVL 2 for the weights between 4 to 20 kilos, and GVL 2.5 for the weights between 10 to 28 kilos. These kind of airways are very difficult to manage, actually, and lidoscope can be very helpful in maintaining and protecting the airway for a patient with something like a retropharyngeal abscess. Be aware that the shape of the pediatric glycoscope blade varies significantly with the size to accommodate the differences in airway anatomy. This may mean that selecting the next size smaller than recommended for the weight child may prove a better view. Sometimes you need to have two blades at the same time to make sure that if one of them is not working and doesn't help you, the other one may help you. But in pediatric airways, what constitutes a difficult airway? Multiple studies have shown that laryngospasm, failure to ventilate, and failure to intubate have been the leading causes of respiratory events, resulting in cardiac arrest in healthy children. It's easy to see that managing a pediatric airway is more challenging than in the adult in the best of times, when complicated by infection, foreign body aspiration, or congenital anomalies. The situation becomes more intense. Even the experienced intubator will be tested in these kind of circumstances. Signs of a difficult airway include edema or bleeding in and around the oropharynx, congenital facial anomalies such as facial asymmetry, chin that is short or hypoplastic, limited opening of the mouth, limited range of motion of the neck, prominent overbite, very large tongue, such as a patient with macropolosia, poor visibility of the uvula, extreme obesity, often with a short neck and significant double chin. History of sleep apnea, larynx, which is fixed to the midline by a tumor or scar, neck mass, vocal cord abnormalities, and mucopolysaccharidosis that can fuse the atlanto-occipital vertebra. When you have these kind of situations, you expect difficult airway. Who is the right person for those kind of situations? In your career, you will encounter children with difficult airways from either acute processes like epiglottitis, like the figure that you see in figure B, or chronic conditions such as congenital anomalies. You must realistically assess whether you have the correct skills, and if not, what you can do to optimize the situation to maximize safety for the child. Then ask yourself, can I ventilate this child? Could I use a supraglottic airway like a laryngeal mask airway? Will intubation be difficult because of anatomy, swelling, or infection? In figure 1, you can see a normal larynx in the toddler, but in figure B, you can see severely swollen epiglottitis of the toddler. Epiglottitis can result in severe airway obstruction and difficult intubation. Only an expert or a provider working with an expert airway management should attempt intubation of a child with significant airway abnormalities, unless a life-threatening emergency exists. Of course, in that case, you want to do whatever that you can do. But in an elective situation, always ask for an expert person. Seek the advice and assistance of any available experienced intubators around you. Consider having a surgeon available for surgical airway intervention if loss of the airway is a serious risk. If the expertise to manage a particular child's airway is not available and conditions permit, transfer the child to a more optimal location. Of course, again, if it is an acute emergency situation, you do whatever that you can do for a patient. As you can see in figure B, a child with severe mandibular hypoplasia. The chin and forehead don't line up. This child required blind nasal intubation, which must be done by an expert person. On the figure A, you can see a patient with large tongue and tense swelling from a cystic hygroma under the chin. This is a very, very difficult airway and must be done by a very expert person. Caveats if you must proceed in the presence of airway obstruction. In the presence of airway edema, you may be able to avoid the need for intubation by treating with steroids, racemic epinephrine, and cool humidified oxygen. Sometimes the situation can be managed medically. At least the patient gets better. But in a situation like epiglottitis or croup, the compensation usually develops slowly, giving you time to attempt medical management. Obstruction from foreign body aspiration can occur rapidly and unpredictable, as the aspirated object is free to move from partial to total obstruction without any warning. Airway burns also can progress from minimal to complete obstruction as edema can be worsened. Always try to keep the parent with the child to avoid crying and agitation, which will worsen swelling and obstruction. If intubation is required, consider bringing a child with the airway compromise to the OR. There, a gentle general anesthetics induction can be performed using spontaneous ventilation in a setting with equipment and personnel to minimize the risk of any harm to the patient. Sometimes a rigid bronchoscopy in children younger than 8 years may be preferable, and it can be done in the setting of the operating room. This was my lecture about the airway. Of course, it's a lot of subjects that could not be covered here, but at least I hope that it was a kind of refreshment for you, and to be able to take care of your patients in a very, very safe situation. Thank you very much for having me again, and I wish you luck and healthiness. Thank you very much.
Thank you very much, Dr. Ghaffari. I'm so happy and I'm so glad to know you, and I should thank you for your kind participation in this session, and also arranging all the session and inviting other lecturers for this session. Your kindness and your attention towards TUMS was a great chance for us to know other great lecturers that have been participated in this session. Sadly, we have passed the arranged time, and we have a little time to just have a short. Sorry, I lost. I mean, I'm online. Okay, so Nima, can you just share your opinion just in a very short time? Thank you very much, Nima.
Hello, everyone. Thank you for awesome present. It's an honor to participate in this panel. And thanks all of the professors. Maybe you don't believe, but in our center, we don't have any devices for difficult intubation or like a glidoscope, like video laryngoscope or gambuji, or for example, supraglottic airway device. We only have LMA and laryngeal mask airway, and we don't have any medication. For example, vecuronium, recuronium, rocuronium. But your very best lectures help us and conduct us. And I have a question. Excuse me, Ehsan. I know that I have a little time. My field of activities, pediatric cardiac anesthesia. We have some infants and neonates that should undergone cardiac surgery, and we use cardiopulmonary bypass for them, and they would intubate for 3 to 4 hours. Do you recommend simple ET tube or cuffed tubes? Which one do you recommend for that? Thank you.
So this is open up panel. Oh, thank you, Dr. Ghaffari.
Thank you for having me here. I think for that kind of surgeries like cardiac surgery, which the duration of anesthesia can be between something like 3 to 4 hours or more or less. By having cuff tube, you might be able to to control the ventilation better in terms of tidal volume, in terms of controlling the PIP, and also to prevent the losing the air and having more control over the patient. I like to actually use the knowledge of Alicia and also Luis in this. What do you recommend for a big surgery like cardiac surgery for a pediatric, like 1-year-old in congenital heart surgeries?
Perfect. Good evening, and I hope you can hear me well. Usually for large surgeries, and if you don't hear me well, let me know, but I'm just assuming that you can hear me. But in big surgeries, yeah. Thank you. So we, even in our center that we do livers and multivisceral transplant, that is from 8 to 12-hour cases, we tend to use cuffed ET tubes. The way we do it is as soon as we put the deflated cuff and make sure it's in the right position, we close on the anesthesia machine the APL valve to 20 centimeters of water pressure. And if we hear a leak, we are listening with our stethoscope, and that way you put enough air to occlude that pressure. And with that, you'll be able to ventilate throughout the case regardless of the time, but also control for any potential swelling. And also, if considering nowadays that there's some centers that are doing something that is called fast tracking, where you extubate after major surgeries like liver transplants or even open heart, you can do at the end, you deflate the cuff, and if you have enough leak, it's called the leak test. Basically, you have enough space around the tube that sort of assures you that you don't have enough swelling, that if you remove the tube, you won't be able to ventilate. So that's something that we recommend, and that's sort of our practice.
Thank you.
I would add that, especially for certain cases, such as you mentioned, that go on cardiopulmonary bypass, there are moments of time where the lungs become deflated. And by having a cupped tube in place, you can generate the necessary positive pressure required to do things that the surgeons will sometimes request, including reinflation of the lungs. Additionally, they'll ask for Valsalva maneuvers or extended positive pressure to look for bleeding. And by having oftentimes I find with an uncuffed tube that you really can't generate the types of pressures for some of these other necessary maneuvers. They'll look for venous bleeding with a Valsalva with that extended back pressure. So I think that's another reason to, and then you just have such a complication, right? These are big cases. There's lots of permutations of the physiology and the hemodynamics that if you can ensure that you have the adequacy of controlled ventilation with a good seal, that's one less thing you have to worry about. And I think the other side of the coin of maybe some increased laryngeal edema is minute in comparison.
Thank you.
Dr. Malikian, dear Dr. Malikian, is there any points that you want to ask or add to what has discussed up to now?
Hello, everyone. Hello, everyone. Thank you, the speaker for your nice and informative presentation. We enjoyed a lot. Dear Professor Rodriguez, we use a combination of IV and inhalation anesthesia for rigid bronchoscopy often. And I have a question. Do you recommend any opioid for rigid bronchoscopy or use in your practice?
We currently do use, and it is traded to maintain your goal. In our scenarios, or what I tend to practice is using rigid bronchoscopy. As you understand, there's enough stimulation, but we want to balance if the foreign body is in the upper airway or in the main airway. If our goal is to maintain a spontaneous ventilation, you have to cautiously titrate your narcotics. So we would probably use, the most common we use in our operating rooms is fentanyl. So we would aim to start at 0.5 mics per kilo, one dose with the goal of maintaining stimulation, added to the other medications as we recommended, where you're using maybe propofol, topicalization with lidocaine that help blunt that stimulation during rigid bronchoscopy. If the foreign body is further down the trachea, or the child will still be intubated after removal of the foreign body, then you can depend more on the narcotics by blunting the respiratory drive and then continue to use higher doses, maybe of the 1 to 2 mics per kilo.
Thank you very much. Dear Professor Ghaffari, can I ask a question? For which group of patients, of difficult airway patients in children and neonates, you recommend Glycoscope? Application of Glycoscope for all of the difficult airway patients, or one type of ones?
Glycoscope is one of the devices that can be used for, of course, any types of compromised airway. If you think that you cannot give any IV anesthetics, any muscle relaxants to the patient, or you think that the airway is a subject of being obstructed after intervention with anesthesia. So it gives you a little bit more assurance that with the Glycoscope you have a better view. And of course, it's not 100% successful, but it gives you a little bit more assurance. So as I show in the slide, something like a retropharyngeal abscess, or let's say if you think that the patient has a kind of congenital abnormalities in the airway, especially in the upper airway, that helps a lot. Dr. Rodriguez, would you like to add some more information, please?
Of course, and after your great answer, I would like to also say, we tend to use it very commonly if you have the airway device. What we tend to recommend to our residents and fellows during our training is to pick one device and make sure that you practice enough. So that would be the device that you use for any difficult airway. We currently in our center, we have the Pediatric Glycoscope, and we have personally used it in children less than 1 kilo. There are certain techniques to use it the way you have a rigid stylet adapted to the blade, which you can find in the company's instruction videos on how to use it. But obviously, my recommendation is if you have a video laryngoscope, practice with it with the normal airway. So when the difficult airway comes, you have already perfected your technique and apply it to that. Also, adding to, if you have the devices, as I understand each country and each center is different with their ability to access these devices, we have in very difficult airways, we have even mixed the use of the video laryngoscope with a fiber optic, and the tube is placed in the fiber optic. So that way, using both, you can definitely make sure that if there is a tracheoesophageal fistula on a difficult airway, that you actually see with the video laryngoscope the entrance to the larynx, but with the fiber optic, you know that you're in the airway and away from a potential fistula between like the trachea and the esophagus. In these scenarios, you can even go as far as that. But with a pediatric glycoscope, there's many brands, so I don't recommend anyone in particular, but just saying that if you have a video laryngoscope, practice as much as you can, because in children, especially the less than 10 kilos, there are little things that you have to do to perfect your technique.
Thank you very much. Have I 1 minute for Professor Stein?
Yes, you can have.
Thank you. Almost all of the anesthetic drugs according to the animal studies, are neurotoxic. Do you recommend ketamine for younger children? Ketamine has many advantages for children, especially younger children. In some situations, for analgesia or procedures that we use to preserve spontaneous breathing. Do you recommend ketamine?
So if you're purely concerned about the fact that, well, so ketamine works on the same receptors as the majority of the other anesthetics. So it is an Nfda antagonist. There's implications with GABA. So there's still concern if there's that question of neurotoxicity, that ketamine, you're not safe from that because it's the same. However, I think that it has a great place in our armatorium of IV anesthetics. So yes, I do like ketamine in children, especially one, if I do need to do sedation, if there's especially a child who has really high requirements and perhaps an oral midazolam is insufficient, to mix that up with ketamine, or even for our larger children who are more grown and maybe have developmental delays such as autism, to utilize ketamine as part of my sedative is very nice, especially, as you say, to maintain spontaneous ventilation and also for analgesia. So I will sometimes run an infusion of ketamine for some of my larger surgeries that are very painful as part of a multimodal analgesic approach to try to minimize the amount of opioids that I use and maintain an opioid sparing technique. So ketamine, I think, is a great, and sometimes I actually think it's underutilized in some ways, at least in our communities here, and underappreciated. With that being said, and you just always have to keep in mind the potential downside effects, such as increased secretions, the activation of the sympathetic nervous system, and some of the associated fluctuations of the hemodynamics, such as elevated blood pressure and things of that sort. But even in an emergency case, a trauma case with massive hemodynamic instability and hemorrhage, use of ketamine, even as an IV anesthetic to induce anesthesia, is a great option. So I think that from just the standpoint of neurotoxicity and this worry that many people have with the relation to the neurotransmitters that are implicated during, during the high time of brain development, which is basically under age of 2, it's the same unfortunately is propofol and others. But I think that our studies and the literature out there, the body of evidence, is strong enough to say that if you feel there's a good indication to use ketamine in these children, that it's okay to go ahead and do so and proceed.
Thank you very much, Professor.
Thank you for that great question.
I have a question for Dr. Stein. Alicia, there are some promising and positive words about using Precedex, dexmedetomidine in pediatrics. Are these, positive points about Precedex, about using the Precedex with regional anesthesia, or even using Precedex in combined with other general anesthetic medications? It can be neuroprotective in that case too.
That is what the literature is starting to suggest. That not so on the one side, it's trying to look at other types of balanced anesthesia where maybe you could avoid the medications altogether, and that's like the T-Rex study that is looking at a combination of regional anesthesia plus remifentanil, or a short-acting, highly potent analgesic such as remifentanil, and dexmedetomidine. However, what is even more exciting, I think, is this potential for neuroprotectivity, and that you can actually have diminished apoptosis and neurodegeneration with the presence of Precedex on board, or excuse me, dexmedetomidine. So I think that there's kind of two sides to the same coin, trying to see how you can provide sufficient analgesia using some other methods and other combinations. But yeah, and in fact, in our practice within our institution, we are very much upticking the use of dexmedetomidine, and even in our very low weight babies. And I've given it use sedation in some children that are basically 1, 2, 3 kilo babies for their inguinal hernia repairs and things like that. And I've really seen very little fluctuations with the heart rate overall. I mean, you have to be careful with the dosaging, but you can, the safety profile studies that are out there right now are showing that you can even go up to like 3 mics per kilo in some cases if necessary. I haven't done that yet, but that's what everything is leaning towards.
Thank you.
Oh, sorry. Okay. So thank you. I think we're way past our time, but the conversation was so exciting that I couldn't allow myself to stop and ask. So I'm really thankful. First of all, I have to say that sorry, I can, do you have my voice? Is it clear? Because, yeah, okay, sorry. So I just wanted to thank everyone for joining us. It was such an honor. So my dear Aylar, who was the host of this meeting, actually had an emergency, so she had to leave, and I came in her place. But I was in the audience and listening to the talk and the conversation and the lectures. It was really inspirational, really interesting, and really up to date. So I really want to thank you. Special thank Dr. Alicia, Dr. Sina, and Dr. Where are you? Okay, hi, Dr. Lise as well. So thank you. And also Dr. Nima and Dr. Bita for joining us. And our special thanks from our Dr. San, Dr. Aghay, our professor. It was such an honor to have you. Thank you for joining us. So I'm going to take a group picture actually, because this is really exciting. So I want to ask you to keep smiling and from our audiences. So if you want to open your video as well, I will take a group photo, because actually this is the last session of the last day of our Congress, and we will finish our Congress with this amazing hit. So I will give permission for everyone to start their video. If you want to start your video, you can join our picture and we will get a group photo in 30 seconds. Oh, I can see dear Professor Ziai. Hi, Dr. Ziai.
Would anyone be able to share that photo with us?
Yes, we will definitely email you the photo. Yes. But there's a condition. You have to accept to participate in our next congresses as well. Oh, hi, Dr. Rais Karami.
Just let me introduce Dr. Rais Karami and also Dr. Ziai. They are the chief, Dr. Rais Karami is the chief and the head of the pediatric group in Tehran University of Medical Sciences. And Dr. Ziai is one of the distinguished attendees here, and he was also the Deputy of International Affairs in the Tehran University of Medical Sciences for a long time. So just let's go for the picture. Thank you.
Sorry, I was mute. So I was just saying that please keep smiling. I'm going to take a few screenshots and then choose the better one. Okay. 1, 2, 3. I don't know what to say. COVID.
COVID.
Oh, I see other people as well joining us. Okay, so 1, 2, 3. This time say peach, peach. Okay, thank you. I think this is going to be great. Thank you everyone for joining us. I have to thank our participants for this amazing, for joining us. Yeah, especially Dr. Ghaffari, Dr. Stein, Dr. Rodriguez, and all of our guests and all of our audiences and all of our lecturers for the whole Congress for all of these 5 days. I can't thank you enough. Hope to meet you guys in person one day in COVID-free days. Please stay safe and come visit us in Iran if you can. Bye.
Bye. Thank you.
Bye.
Take care.
Thank you for this opportunity.
Thank you. The opportunity was ours. Thank you.